So, Dr. Esposito, would you be happy to share with our listeners just a little bit of your background ultimately? Anything that you're happy to share for those that aren't familiar with you or your work?
Absolutely. So I was born and raised in New York, right outside of New York City, and I grew up kind of a heavy, chunky, or as they would put in the clothes section, husky section. And my father, at the age of 49 or 50, had his first, actually had two heart attacks, and
Okay.
I was about 7 years old. And then I always thought, medicine will like cure him. Medicine will fix his issues. Like there, I don't need to worry about anything. And what ended up happening was he started getting progressively worse with smoking and alcohol and etc. And what ended up happening was he started deteriorating. And I saw how nutrition played a functional role in his health. So I knew I wanted to go into medicine and I knew I wanted to go into preventive medicine. And as I was getting older, I realized well, conventional medicine really has nothing to do with that. All it has to do with is making sure that somebody doesn't die, which is great. I mean, they're awesome at putting out fires.
Right.
I'm more about putting out the match before it gets to a fire. So then I went to NYU undergrad. I did my nutrition degree there, so I have a bachelor's in nutrition. And while I was there, I started as an intern, a medical intern at NYU Urology with Dr. Espinoza and the whole NYU Urology Center. And I was there for about 7 years, all throughout 6 years, all throughout med school and part of undergrad. And that's when I actually became infatuated with urology, men's health, hormones, anything that had to do with the endocrine system was really kind of my thing. And all throughout med school, my background in nutrition allowed me to kind of understand biochemistry on a deeper level and how we can manipulate that. So I think I had a little bit of an advantage because as I was going through med school, and this is naturopathic medicine. I probably should have mentioned that I'm a naturopathic physician and I'm also an acupuncturist. So as I was going through medical school, I started using nutrition as the lens of most pathologies at a biochemical level to see how they can be manipulated. And then after that, I basically, published a few papers and textbooks and etc. and ended up going into private practice. And now I work as a physician and a medical consultant and a research analyst for a practice here in New York. So that brings me to a place where I get to super specialize in particular areas because I'm able to spend time. Part of my work time is to dig deep into the research. So if it's out there, I probably know it. And if I don't, I will figure it out.
Brilliant.
Yeah.
And is there anything that really kind of drew you to sort of urology and hormones, or was it just an innate appeal?
Well, this was kind of during the Barry Bonds, the Major League Baseball, American baseball, where Barry Bonds and Sammy Sosa and Mark McGwire and Roger Clemens and Andy Pettit and all these American baseball players were doing steroids.
Okay.
And I always thought to myself, I'm like, geez, why do they have to go that route? Now I understand why they went that route. But I thought there should be ways to optimize this. And being a guy and a group of guys who always wanted to like be bigger, faster, stronger, and it just became something that I was infatuated with. But really, Alex, I think what it comes down to is the fact that this is how my mind works. Some people draw art and it's just like they do it. Some people are great with numbers. Like they could just do algebra in their head or calculus in their head. For me, it's just hormonal pathways and endocrine stuff just it sticks. So most people see pathways in 2D and I kind of see them in 3D, right? So I see where everything is coming in, which is which is more of a network. not necessarily a pathway, because a pathway indicates, right, it's a road. You go down
Mm,
this road, make a left or a right. But networks are actually three-dimensional. And that's more of how I think in terms of hormones and health and basically medicine.
brilliant. Yeah, I really like that analogy actually. It makes a lot of sense because comparing pathways to networks. We had
Yeah,
Pete Williams on the show a few episodes back, and we had a brief conversation around systems biology and I guess how it fits in with the functional medicine model and what it is. And I guess it's the same kind of thing ultimately. It's appreciating the complexity.
exactly right. And the thing with functional medicine is it's it's bare bones science. It's biochemistry, it's biology, it's chemistry, it's anatomy, it's physiology. Like if you understand that stuff, you can be a good practitioner. Unfortunately, in the medical model here we have in the US, most practitioners are not doing the thinking process. They're doing the doing process. So so by doing the doing process and disregarding the thinking process, what happens is people just continue to do what is a protocol and not actually think about what that could be having or what the actual cause is. You know, blood pressure, okay, just give them an antihypertensive, an
Mm,
ACE inhibitor, a calcium channel blocker, a diuretic. I can tell you why those things are working, but it doesn't tell me why those things are off.
right. Okay. No, it makes complete sense. So, obviously, today's topic is around men's health, and we can dive into a few specific topics. But I'm going to, I guess, throw a big question out there to get us going, which is if we're on this topic of men's health, I guess, how and where do you want to start with the conversation? And to help with that, are there any broad perspectives, or are there any big things that we can touch on initially which might help us then dive deeper into some of the more specific topics around maybe prostate health, for example?
Sure. I think what it comes down to on a broad level is men don't want to go to the doctor. Pretty simple. Men will fight going to the doctor. There was a study that came out from the Cleveland Clinic that showed 40 to 50% of men will discuss their health issues with their partner before they'll even discuss it with their doctor.
Hmm.
So that is already a barrier to health, number one. Secondly, people are utilizing the internet, Google, Instagram, Facebook, Twitter, as nutritional or medical knowledge. But those are all opinions. And even if you look at my social media, a lot of it is my opinion, but I do the best to be agnostic. And I think if you look at an overlaying picture to kind of address men's health, I think the number one answer or the number one thing to pay attention to is that everyone has their biochemical individuality. And if you are biochemically unique, then what the next guy says may or may not apply to you. So, as an overarching kind of theme, is you need to see a physician. You need to see somebody who actually understands what they're doing and don't mistake Google as a medical degree.
Okay. I really like that actually. It's not where I thought we were going to go, but I think it's a really important message. This idea of how open are we speaking with anyone about our health issues, and if only 40 to 50% of us are happy to even speak to our partner, then it's kind of a worrying statistic, as you say, straight off the bat.
Absolutely. And the thing is, men will ignore these issues. Like, for example, let's just talk about two topics. Number one, cardiovascular disease and let's say prostate disease, prostate cancer, enlarged prostate, prostatitis. The two are connected. Well, not many people realize that, but they are very much connected. And the penis is a barometer of your health for men. And by assessing a man's sexual health and the hormonal health and their prostate health can give you a preliminary insight into their actual overall health. And not many practitioners will identify that or even pay attention to it. So, what I say is for men to actually pay attention to those things early on so that you can correct them later on. And so that they don't become an issue later on, because there's many studies showing, actually two more recent studies showed that men who they did carotid Dopplers, so they checked the plaque in their carotid arteries, which goes to the brain, and then they also checked Dopplers on their penis, so basically arteries and veins that are in their penis, and they found the correlation. And it was a pretty strong correlation. I believe the odds ratio, relative risk was above 2, which is significant. I mean, most people will say, well, an odds ratio above 1.3 and 1.4 is important, but when you get to 2 and 3, there's a strong correlation there, and it's not causal, but it gets closer to, there's something to pay attention to. When they found that these men also had erectile dysfunction. So I see a guy who has ED, the first thing I'm thinking of is, what's his cardiovascular health like? Because ED is not going to kill him, but heart disease and a heart attack and a stroke certainly will. So I think that's something that's really important that men really need to pay attention to. And the big thing, Alex, is majority of this stuff is preventable.
Yeah. Yeah, and one of the thought that comes to mind is also how comfortable, willing, and is the practitioner to be asking the questions? Because I imagine that's also quite a big barrier sometimes.
Absolutely. And I see this more of an issue with female practitioners and vice versa. A lot of male practitioners don't want to ask women about their period, or, are you having pain with sex, or, what is your period like? What is the color like? Clotting, cramping, etc. And the same thing with female practitioners, or even male practitioners with other male patients. I don't want to talk to this guy about his penis health, and he probably doesn't want to talk about it either, because he might either be embarrassed or he's like, well, that's private, right? And I think it's something that we kind of have to just open up about, right? It's kind of probably a pretty bad comparison, but 15 years ago, it was looked down upon if you were homosexual, right? Like, oh, I can't tell people that. And now there's like LGBT and a bunch of support, and transgender athletes and practitioners and et cetera, which is super supported. And here in New York City, it's like, it's the average, right? It's like, okay, so big deal, you're gay, whatever. And I think that's the approach that we have to take with men's health, is like, okay, so your penis doesn't work right now. Let's figure out what's going on. And I think for your listeners who are practitioners, or even your patients who are men who are having this issue, it's just saying it. You can't go about and think, oh, so like, as if I was a practitioner. So, like, sometimes men in like their 40s and 50s, sometimes, like, they're and they just start beating around the bush. Just come out and say it. Like, hey, erectile dysfunction is an issue in men around this age. I noticed that it might be an issue for you. Let's talk about it. But even if you don't want to do that, you can do, there's questionnaires, like a IIEF score or a SHIM score, which can tell you sexual health or erectile function without actually talking to the patient, and use it as a screening tool and say, hey, notice your numbers are a little bit off here. Let's fix that. So that's a great way to talk into it, but really just go in and be confident and just be like, we're going to talk about penises and prostates and sex. And yes, I'm going to feel your prostate by putting a finger into your butthole and figuring out if there's a risk of prostate cancer or whatever. Like we need, that conversation needs to be had, because prostate cancer is one of the top killers in men. So if you told me that there's a disease that you can get that is preventable, sign me up. Like, let's prevent it. I don't want any part of that. Now, other conditions, like getting hit by a car, you can't prevent that. Like, I mean, you could look both ways before crossing the street, but it's less about your actions and more about others' actions, right? But if you told me that you can prevent prostate cancer, enlarged prostate, low testosterone, hypogonadism, erectile dysfunction, then you can do all that via diet, exercise, lifestyle, sleep, supplementation. No medications are necessary. So that's kind of the approach that I would like to take with practitioners. And part of my job is I don't, aside from the practice that I work at, I don't see patients privately. So most of the people who reach out to me are other practitioners, and they want to talk to me and say, "Hey, I don't know what to do here, right? Like, what should I do?" And I'm like, "Okay, this is going to be a long process. I don't have an hour to kind of treat your patient, but here's a few things to look at. Here's a few tests to look at. Go ahead, figure it out." And pet practitioners come back, it's like, "Wow, I would have never ever thought about that." I got a text message this morning from a colleague who's like, "Hey, look at these numbers. Tell me what you think." I was like, "Yeah, this person's on Clomid, or he's on some type of um, performance enhancing drug or some type of anabolic." And the first thing she thought was, "I don't know what to do. Like, let's send them to an endocrinologist." And I'm like, "Just think about the physiology. Just think about the physiology of it, and it'll lead you in the right direction." And we ended up figuring it out. So it's kind of it's it's not so complicated, but you just have to have the right mindset. And I hate to say this, but the more you know, the more you can parse out and identify what's BS or not.
Right. No, that's brilliant. So you've mentioned a few things around supplements, lifestyle, stress, sleep, exercise, diet that are significant factors that will modify someone's risk ultimately. So are you happy to dive into a little bit more of what you've read around the research? So some of the specific things that we might want to be considering. Obviously, it's going to be from a generic perspective, but some of the dietary and other lifestyle considerations and maybe some supplements, and feel free to add more context to make this a bit more relevant for you as well. But what are some of the things that for certainly the general public listening, they want to be mindful of when we're talking about male health and maybe in particular prostate health, as it seems to be such a prominent condition?
Yeah, I think if you take nothing else away, excuse me, if you take nothing else away from our conversation, number one, sleep over everything. Sleep is number one. We have evolved over millennia to, adapt. We've changed our diets and we've adapted. We have changed our environment and we have adapted. Some people better than others. The one thing that we have not adapted to is sleep deprivation. So if you do not sleep, I promise you, I can guarantee you, I don't guarantee much, Alex. So listen, I can guarantee you that if you do not sleep, your body will not function. Your hypothalamic pituitary adrenal gonadal thyroidal axis, the HPA-GT, will not function. I promise you that it will not. Some people are more resistant than others, but it will dysfunction, if not now, then later. So number one is sleep over everything. And it's also about healthy types of sleep, right? So it's not about sleep quantity, it's about sleep quality. So yeah, you can sleep 9 hours, but if you're waking up 3 times a night to urinate because your prostate's enlarged, or you're waking up at night because you aren't able to rest your unrestful mind, then your quality of sleep will certainly decrease. So number one is sleep over everything, and we can certainly talk about deep sleep and slow wave sleep and REM sleep and et cetera, and things that we want to look for. Secondly, and I think this is probably, I really wish that this was not so controversial, but a high carbohydrate diet does not benefit most individuals, and especially a high processed carbohydrate diet. And I know there's people in the field of, vegetarian and vegan where their carbohydrate intake is higher. But I think one thing that we know is that hyperinsulinemia, so high insulin levels, stimulated by a frequent high carbohydrate diet or sugar, will have an impact on male health. And the reason, I mean, I can go down to multiple different pathways, but really what happens is when you have hyperinsulinemia, you are upregulating pro-inflammatory pathways, and you're changing the activity and function of different enzymes. And one in particular would be aromatase. And by increasing activity of aromatase via insulin, which does it via the stimulation of certain cytokines like interleukin 6 and TNF, what it will do, it will upregulate aromatase in men. And that will push the conversion of testosterone to estradiol and estrone. And most of your listeners probably understand that aromatase, estradiol is a kind of female hormone. Estrogen is a female hormone, and men should not be having a lot of that, because what it can do, it can lead to further adipose tissue deposition. And actually, I know that the cause of most prostate diseases, prostate cancer, and enlarged prostate is not testosterone. And it's not even dihydrotestosterone or DHT, which a lot of people are taught in school. I mean, I was taught it too. DHT is a potent, 8 to 10 times stronger than testosterone. It's going to cause your prostate to enlarge. It's going to cause your hair to fall out. But really, what's not understood is the metabolites of DHT, something called 3-alpha and 3-beta-diol, and the binding of those to estrogen receptors, which will then stimulate the prostate to grow and can make the prostate cancer cells more sensitive to hormonal changes, which then creates a hormonal milieu that is intolerable to fighting cancer. So you're basically giving the body a microenvironment that is not resistant to metabolic changes and physical changes, which then leads to enlarged prostate, prostate disease, prostate cancer, etc. Now, I'm super happy to go deeper into that. So you just say the word and we could talk more about that.
Let's do it. Yeah.
Okay, great. So what happens is these estrogen receptors. So you have estrogen receptor alpha and estrogen receptor beta, and each one has a different action. And the beta metabolite, or the beta subunit of the estrogen receptor, is more anti-proliferative. So it prevents proliferation, whereas the alpha receptor is hyper-proliferative, which basically means if you're binding to the alpha receptor, you're stimulating growth.
Okay.
Whereas if you bind to the beta receptor, you do not stimulate growth as much, and you promote differentiation. So when we see prostate cancer and you do a biopsy, and the Gleason score, which is a score that helps grade your cancer, they're basing that on how much differentiation there is in the actual cells. So put simply, how close do these aberrant cells look like normal cells, and how close do they look like non-normal or cancerous cells? And really that has a lot to do with the way that they're growing, and what stimulates their growth is estrogen. And the metabolites of DHT, something called 3-alpha and 3-beta-diol, bind to those receptors. So the 3-beta-diol is a little bit more protective than the 3-alpha. And we kind of see that with 5-alpha reductase inhibitors, because we know 5-alpha reductase inhibitors decrease the conversion of testosterone to dihydrotestosterone, which is why we think that these things can be helpful for prostate cancer. But really what we're looking at is the next step after. So, and there is a little bit of mixed research showing that some of these 5-alpha reductase inhibitors may not actually prevent prostate cancer. And that's because they're not having an impact on the 5-beta reductase. Okay. So you have an imbalance. And they're not actually addressing estrogen and estradiol and estrone. And then secondly, the estrogen metabolites like 2-hydroxyestrone, 4-hydroxyestrone, and 16-alpha hydroxyestrone, which are the metabolites of estrone or estradiol 2-estrone, which then goes to these metabolites that will then bind to DNA and cause DNA adducts. And these DNA adducts are basically damage to the DNA. So in order to have cancer, it's a metabolic and a genetic process. So the metabolic process are the changes in insulin and blood sugar um, and estrogen, and the DNA process is what those things are doing to the DNA that's causing these mutations, which then causes the prostate cancer cells to look different, and that's prostate cancer, right? And we see that also in BPH and enlarged prostates, where it's actually not the dihydrotestosterone, but it's the estrogen metabolites and estrogen that is actually binding to these receptors that are causing the prostate to enlarge. And even sometimes we see give people DHT blockers or 5-alpha reductase inhibitors, and it really doesn't help their enlarged prostate. And that's because it probably has very little impact on how much the prostate is, the certain area of the prostate is enlarged, which, depends on if it's constricting the urethra or not. So all of these things are manipulated by your diet, right? Because you can control your blood sugar levels. You can control how much you exercise. You can control how much you sleep, which will have an impact on these enzymes' activities, which then determines what they favor or not. So it takes a network mind to kind of put this all together, and I just hope to kind of broaden the picture for some people so they can understand this a little bit better.
That's interesting, and I think it's a great example of how physiology is incredibly complex, but again it goes back to, well, what are the recommendations, what are the interventions that can modify this complexity, and those things are often relatively simple, but they're lifestyle factors. Okay.
Absolutely.
So am I right in saying that you mentioned 5-alpha reductase inhibitors, for example, and are some of the, if I use the term natural alternatives, are we talking things like zinc and nettle and those kind of prostate support almost supplements?
Yeah, so those things have activity on the 5-alpha reductase and the aromatase enzymes. Nettle root typically has an impact on 5-alpha reductase and sex hormone binding globulin.
Okay.
But caveat is a lot of those studies were in mice, so the doses in humans have to be very high.
Right.
Typically, above 600 milligrams, and most supplements have about like 150, which I look at it and I say, oh, that's cute. That's nice, right? And then zinc, certainly, and the other one I really like is saw palmetto, which is a 5-alpha reductase inhibitor. But the studies on saw palmetto as a monotherapy are pretty weak and not quite effective. So there are a few studies showing that saw palmetto with pygeum, with zinc, with pomegranate, and another extract called rye pollen extract can help with reducing symptoms and enlargement of the prostate. Not with prostate cancer. They have no impact on prostate cancer. Don't think giving somebody saw palmetto is going to prevent their prostate cancer. It's not. But pomegranate and these other herbs, also cranberry, can be very effective. That will help prevent enlargement of the prostate and kind of arrest it where it is. And I usually tell men, if you hit 40, this is something you should be taking, because if you're 50 and 60 and you have an enlarged prostate, it's going to be hard to kind of shrink that if it starts to constrict your urethra. So I usually tell people, let's just start with this now. Like, there's no downside. There is zero downside. And if you have a family history, I have no family history of prostate cancer or an enlarged prostate. My father's 73 and urinates fine, right? No history of prostate cancer. PSA levels are excellent. So I'm a little bit lucky. But I certainly am proactive and looking out to be preventive in that aspect.
And I guess it's a bit of a double-edged sword in regards to carbohydrate intake in the context of the general population, who have all of the other variables often that we can tick as well, i.e. poor sleep, sedentary, and processed food. So would I be right in saying that the carbohydrate intake will be personalized around someone's activity levels and there's a bit of a buffer there? Or would you say that essentially a low carb diet is just sort of hands down the way to go?
I think the question becomes is what do you consider low carb,
It's a very good question.
right? According to the Academy of Nutrition or Academy of Dietetics and Nutrition, Academy of Nutrition and Diet, I don't know what they're called now. It used to be called the American Dietetic Association. They're not that
Okay.
anymore, right? A average carbohydrate intake for an individual should be 55% of the diet. Alex, if you eat 55% of your diet from carbohydrates, I will be very upset. Okay? And we can have a whole conversation on the side about that. I won't lecture you. I will just educate you. So if you consider anything less than 55% of your diet carbohydrates as low carb, then we're going to have an issue because putting somebody on 40% low carb or 40% diet of carbs or 30% of diet of carbs, I wouldn't consider it to be low carb. So I look at total grams. And typically I would say a ketogenic diet is usually between 50 to 70 grams of carbohydrates. That's low carb. That's very low carb. That's ketogenic. And I would say low carb would be less than 100 grams, which is 400 calories. That's that's a decent amount of calories, assuming you're eating, a well-balanced diet for an individual. It could be anywhere from like 25 to 30% of your calorie intake, which that's actually a pretty decent amount. I wouldn't consider 100 to 120 grams of carbohydrates low. I would call that about healthy and adequate. So I don't tell people, low carb is the best way to go, but I put it in the context of, well, what are your metabolic markers showing? What are your blood sugar levels showing? What are your A1C levels showing? I do oral glucose tolerance testing. So I see, how are you responding to 75 grams of pure glucose? What is that doing to your insulin levels? Do they decrease? What is that doing to your glucose levels? Do they decrease? And then I determine how insulin sensitive this individual is. The more insulin sensitive somebody is, which is strongly influenced by their cortisol levels and their muscle mass, then I decide, okay, this person needs to be stricter in their carb intake compared to another individual. Now, I have worn continuous glucose monitors to assess my response to blood sugar in real time, which is usually like every, I think, 3 to 5 minutes. And I know what foods spike my glucose, and I know what foods do not. I know that alcohol screws me up, and I know it causes me to spike and then plummet. Oddly, I know sweet potatoes spike my glucose, and they bring me up to about 140 milligrams per deciliter, and it doesn't drop for quite a while. And you would say, well, sweet potatoes have a lot of fiber and they're low glycemic. Not for me.
Amazing.
Not for me, right? And then you look at something like quinoa. Does nothing to my blood sugar. It stays stable. So I can eat an equal amount of carbohydrates from quinoa and an equal amount of carbohydrates from sweet potato, and I will have a completely different glucose response, right? And so how am I to tell you without this information what you should or should not be eating, right? I need to know how insulin sensitive you are. I need to know your fasting insulin levels. I need to know what type of exercise are you doing. I need to know your muscle mass, not so much your body fat percentage, but how much muscle mass do you have? And putting these together, then I can say, well, your carb intake should be on the higher end or the lower end. And then that becomes individualized medicine rather than just saying everybody keto, everybody vegan, everybody paleo. Like that's both crap, right? Like that's not how medicine should be working. It should be individualized for the person. And look, nutrition, your listeners are not going to like this. Okay. Nutrition is the hardest, quote unquote, science to study. Okay. You can't do a double-blind randomized placebo-controlled trial on two groups of individuals eating a different diet because each individual person is influenced by another factor. But we can see trends in studies. And this is what creates, like, I always tell people, I think religion is as equally controversial as nutrition. right? Because it's not what you know, it's what you believe,
Right.
right? So if I say I believe a low carb diet is best, and somebody else is like, I believe a vegan diet is best, oftentimes those two things don't mix, although they can. But now you're saying, well, I believe this. Why? Because I eat and I know, right? Because I'm an expert. I eat every day. Cool. Me too, right? And it's in medicine, I treat people every single day. So yeah, you eat every day, and so do I, but I see, 20, 30 more people than you a day doing all these different diets or et cetera. So a long, a long explanation to your question is basically this needs to be individualized, and to have a one shot answer is would be irresponsible of me, I think.
Mm. No, that's a brilliant answer, and I think it actually gives people some strategies as well. So obviously you mentioned the blood glucose monitor that you've used, and sort of the insulin response. So there are some tools that we can go away and either utilize on ourselves or with our clients to support that. Because I think the takeaway from that for me is it's less about your carbohydrate intake and more about how you are tolerating that carbohydrate intake.
Absolutely right. That is absolutely right because people always use this example and it annoys annoys me. And they talk about Michael Phelps, right? He won X amount of Olympic medals, and the guy ate like 4,000, 5,000 calories a day, and he was eating a bunch of, carbs and all this other stuff. You're not Michael Phelps. You are not Michael. You are not Usain Bolt. You are not these top-notch athletes. You are not Cristiano Ronaldo. You are not them. You are not Lionel Messi, right? You are not these people. So stop trying to compare yourself to these individuals. Oh well, this is the diet that. Oh man, what did I see most recently? About the movie Creed 2. I can't remember the actor's name. Shame on me. Um, but he was also in Black Panther, and he was ripped.
Mm.
And all over YouTube and Men's Health magazines is his workout, his diet. And I don't care about his diet. I don't care about his workout because that's what worked for him, right? It's not going to work for me, and that's an issue that we have with social media. It's like everybody's an expert, Alex. Everybody is an expert on social media because they post something and like, you know, 10 years ago, if you were on TV, even like on the news, interviewed for I don't know, snowstorm coming, and you said on the news, I have to get bread, eggs, and potatoes. Well, you're an expert. Like he was on TV. That person knows. They know. I trust that person. They're famous, and that's kind of like what Instagram is. It's you're insta famous, and it like let's actually streamline what we do. And actually, you'll see in a lot of my posts and blogs, I cite everything. And I give you the option to read it for yourself and say, hey, look, this is where I'm getting my conclusion from. Tell me what you think. And I am totally open to a conversation. Totally, totally open to a conversation. I won't argue with you. I will not argue with you because it's like two people trying to convince each other of something
Yeah.
that oftentimes there's no answer. But I'll give you my view on it. I mean, if you want to talk about celery juice and medical medium, like we can talk about that too. But, you know, again, there's no end there because look, I believe that, right?
Mm.
Rather than saying I know that. So
Yeah.
it's a touchy topic.
It is, and I think, as you say, it's fueled by emotions and beliefs. And I say to clients, look, some of the most intelligent people I know on the planet appear, through my perception of their work, to be blinded by it. They have their way of eating, and they will. I love them at the same time, but they do seem to be quite pushy in that's how we should all be living, eating. And it's something I've thought about a lot recently, just because it's obviously, being a nutritional therapist, it's a conversation that clients are always asking. And I think so many of my clients have, because of things like social media, built relatively rigid rules about how they need to eat to get better.
Mm-hmm.
And I actually think, yes, there are going to be times when there is a specific therapeutic diet that is required, But that's got to be, I think, in the context of a mind which still has that flexibility within it and isn't fixed by those rules. Because as soon as you're fixed by rules in how you eat, it becomes a very black and white, limited world. And I started looking at some of the studies and just thinking about what I've heard from elite athletes, for example. And yes, it's a completely different population. But if we're talking about a diet generally for humans that is related to longevity and gut health and things like this, I think actually some of that information is really valuable and actually starts to challenge some of the principles that red meat is in isolation a cause of bowel cancer, for example, when I don't think we can say that without the context of what else is going on in that person's diet. So context, like you say, and these networks are just fundamental.
You're absolutely right. And one important point that you made there is the context. And a lot of people are using epidemiological studies to make conclusions. A good epidemiologist will tell you, I cannot say this for fact. I cannot say that this is absolute truth. I cannot even say that what I'm telling you is factual. And everything in science is a hypothesis, and everything is theory, right? And what they will probably come back and tell you is like, look, this is what I've seen. This is my observation. This is what the data shows. And it's up to you to interpret that and see what that means for you. And, again, like the red meat causes colon cancer. Well, maybe a lot of the people that they studied who were eating a lot of red meat who did have colon cancer were also drinking a lot of beer. So they're having ribs and beer. Or these individuals were having, a high carbohydrate diet. Or these individuals were having a lot of alcohol, or they were smokers, right? And a lot of the stuff they try to assess for other confounding elements, but it's really hard to assess for those things in diet. So even if you told me red meat is associated with prostate cancer, I will tell you that that is very weak there. If you think that abstaining from red meat is going to save you from getting prostate cancer, that's not true. And if you told me that you've had prostate cancer and you should abstain from red meat because it causes prostate cancer, that is also not true. But what we do know is that there's been a strong correlation with a vegetable-based approach that is protective. And that's pretty consistent. What we're seeing is men who typically eat more fruits and vegetables, more vegetables than anything else, their risk of prostate cancer does decrease. And that's consistent over multiple different studies. But if you tell me that red meat causes a particular type of cancer or a condition, and it's incongruent among the literature and the data, then my question is if this were so true, then why is it not consistent? We can't even say like cigarettes cause lung cancer, right? It's strongly correlated with a risk ratio above like 4 or 5. Like, it's pretty obvious that these things, smoking is a strong cause of lung cancer. But if you smoke does not necessarily mean you're going to get lung cancer, right? So we have to take all of this into consideration and context. So it's such a touchy topic that I'm even reserved at telling somebody I know something. I just tell them, like, this is what I think, and this is the data. And look, and I want to make a very strong point, important point. The individual who knows what they know and knows what they don't know is much safer than the individual who does not know what they do not know. So a lot of these people who are telling you like this is the only way to eat is probably because they don't know other things, or they do not know the things that they do not know. So I can't fault them for doing something and saying, hey, this is how you should be eating. And I can say, well, I disagree with you because maybe I know something that you don't, or maybe you know something that I don't. And I love nutrition because I'm always learning and I'm always adapting, right? So we were just talking before we came on about, fasting. And we can even, if you want to talk about time restricted feeding and intermittent fasting and, water fasting, I just finished a Walter Longo's fasting mimicking diet. And, how do I know that's going to help me improve my longevity? I don't know for sure. I don't. But I do know that from from traditional naturopathic medicine and traditional Chinese medicine and Ayurvedic medicine, which have been around for decades and millennia, right? Chinese medicine is 2 to 3,000 years old, and Ayurvedic medicine is even older. They fasted. And I will take, 2,000 years of passed down knowledge from ancestral physicians or doctors or healers and say, hey, there might be something to this. And now we have a diet that says, hey, if you don't eat a lot, if you eat 700 calories 5 days for 5 days every other month or whatever it is, you're going to live longer. I can see how that fits within my model. And I can say, okay, well, that makes sense to me. So then I try to apply it because really in the end, Alex, as a physician and even as a nutritionist, you're practicing, you're not knowing. And people need to understand that.
Yeah, absolutely. And I think it's also a really key point for times when we're suffering with disease, because again, I think there's this idea sometimes that there is an answer and there's a specific program that's going to get me better. And to some degree, obviously with a bit of flexibility, that's true. But again, it goes back to this idea, look, there isn't this magical, or there isn't this perfect program that you need to follow perfectly to get better. And again, it comes back to context and the bigger picture. So I think that is a really critical point for physicians, clinicians, and clients and patients ultimately. It's the idea of, I guess, seeing the forest through the trees, if that's the right expression, or the other way around. I always forget what the expression is.
I have no idea. Not a clue.
We'll just pass on from that then.
Yeah, I believe you. I'll just take that as fact. But on top of that, it takes 2 points to make a line. And it takes multiple different points to make a trend. So if you are at rock bottom and you're telling me I am here, I need help, and your next point is at, optimal health on the graph chart, well, it takes 2 points to make a line. So you're at rock bottom, and it's not a linear line to optimal health. It is not, unfortunately. And even in nutrition, people get setbacks, but the goal is to increase that slope, right, and make sure that you're moving in the right trajectory. And that's nutrition. Like, no matter what anybody tells you, you're not always going to be eating the right thing. And the thing that you're eating is not always going to be the right for you in that circumstance. So I've suffered with IBS my whole life. And in the past 2 to 3 years, actually, Dr. Gabrielle Lyon was a huge help for me. We were able to, and actually one of my best friends, Dr. Tara Nyack. So 2 people that I just said, hey, look, take my health, take it and put it in your hands and help me, because I can't be objective in my health, because you can't treat yourself. And that is a really important part of nutrition, is that understanding that a lot of this information is basically going to have to take a lot of trial and error. And I reviewed a recent paper on the Mediterranean diet and prostate cancer. And I saw in that paper that they were trying to make the conclusion, I was a reviewer, and they were trying to make the conclusion that a Mediterranean diet prevents prostate cancer because of the data showing that lycopene in tomatoes and olive oil and omega-3 fatty acids are protective against prostate cancer. And I see where they were going, but you can't make that conclusion. You cannot say because lycopene in tomatoes and olive oil and fish, because they're part of the Mediterranean diet, that means the Mediterranean diet prevents prostate cancer. Can't do that. That's irresponsible. But what I can say is the Mediterranean diet compared to the standard American diet is far superior in preventing probably all illnesses. So there's things that I know and there's things that I'm not quite sure of. And that's something that I absolutely know. And if anything, if your listeners take anything away from this conversation, it's like nutrition is tricky. And if you can go into it and just think, I don't know a lot, you will always learn. I'll admit to you, like, I'm a dummy compared to like what is out there. I don't know a lot, but I probably know enough to make my own thoughts and processes and try to understand things on a different level compared to the individual who thinks they know a lot and is so infatuated with their decision. So we're getting really philosophical here.
No, it's good. I like it.
I don't know. I mean, I want to give your listeners like hardcore stuff to go home with, and I think this is kind of hardcore stuff that they can utilize. And I think it's really important for them to just continue to learn. And a lot of functional medicine practitioners and individuals, they kind of just take everything that an organization will say to be true, and that can be oftentimes a double-edged sword, because IFM, Institute of Functional Medicine, does an exceptional job. I've done all their courses and their modules. They do an exceptional job at citing certain things, but I think even they would say that there's still more that we don't know, and that's why they're improving mostly all of their protocols and educational material every few months.
Right.
And that's the telltale sign of a highly respectable educational tool.
Yeah, definitely. I mean, the rate at which science is evolving, it requires updating content on, certainly like a quarterly basis ultimately. But if you want to, and I think we are, we're hitting some of the hardest core stuff, I think. But one thing I was going to ask you on, because it came up in I guess a little bit of PubMed surfing that I was doing for our chat today, was there was actually a lot coming up around toxicity and sort of prostate health and male health. So is that something that you've sort of read around as well?
Toxicity as in environmental toxins?
Yeah.
Yeah, I think, so when you say toxicity, it's such a ambiguous word. Are we talking about like, PCBs? Are we talking about BPA? Are we talking about heavy metals? Are we talking about a toxic lifestyle, like not meditating, poor negative thoughts, which I consider to be toxic, putting you around other people who just suck? Like, what is considered toxic?
I saw heavy metals. There was a paper on lead. And then there were a couple, I think, on sort of pesticides, herbicides type stuff.
Yeah, what we do know is that typically organic vegetables, and particularly the Dirty Dozen, which are probably the most contaminated, blueberries, berries, celery, bell peppers, etc. The glyphosate and the other pesticides in there can be problematic for individuals in promoting prostate cancer. I don't think we've actually had a conclusion on that. Regarding lead, I do know that heavy metals can be problematic. Anything that will disrupt the DNA in your cells will be problematic. I mean, you can't argue that. That's what we know, and that's part of the cancer picture. So we know that. But lead, I've seen more as an issue of disrupting the hypothalamic gonadal axis, hypothalamic pituitary gonadal axis, and what it can do, it can actually cause primary hypogonadism, so it can actually damage your Leydig cells in your testes. Lead is probably one of the most problematic metals in terms of low testosterone for men, beyond arsenic and cadmium and mercury, although those are problematic as well. And secondly, lead can build up, can accumulate in the pituitary gland, and it can impact the sensitivity of your pituitary to the negative feedback system. And it will impact the body's understanding of what's high and what's low. So you'll see individuals with very high luteinizing hormone or very high FSH or very high cortisol levels, and the message is not getting back to their brain. And that can be because of metals, which are contaminating and toxic to the function of these individual cells. And really what it's doing, it's damaging the mitochondria in those cells, which are responsible for making hormones. And people don't realize that your mitochondria is what makes your hormones. Like, okay, yeah, it's my, testes, or it's my ovaries, or it's my adrenal glands. Yes, but it's the mitochondria in those glands that are making the hormones. And that is what's disrupted with heavy metals. And that's where this whole idea of like mitochondrial dysfunction, which I frankly don't know a great way to measure it. But I know that perhaps optimizing function is likely going to improve function. Um, uh, so it's really hard to measure, but certainly, yes, if your lead levels are elevated, I utilize other testing, and I'm not sure if you want me to share the type of testing that I use, but there's a bunch of different functional medicine labs that you can use that'll test heavy metals, that'll test your adrenal glands, and et cetera.
Perfect. Okay, no, it's good to know. I'm mindful of time, Ralph. So, is there anything that you would like to conclude with? Anything you want to sort of reiterate or add to the mix?
Yeah, I don't think maybe I did, but perhaps not strong enough. I think the most important aspect is for people to understand that sleep is super important. And your slow wave sleep or deep sleep is the phase of sleep that you're making a lot of these hormones, where you're recovering, where you're repairing. And if this is not happening, then everything that I told you earlier will not function well. So you have to correct sleep. It should be at the middle and foundation of your healing plan or your treatment plan or your prescription. And if you can correct sleep, then expect everything else to work better. And I would like your listeners to kind of look up something called allostatic load. And in short, what an allostatic load is, and not many people understand this, and I think this is where a misconception comes along with other practitioners who are not into integrative medicine, is your allostatic load is basically, when have I hit my threshold? And it's a question that people always ask, like, I've been eating dairy my whole entire life, and now I can't eat dairy. Or I was pregnant, and after I got pregnant, my thyroid was destroyed. You've hit your allostatic load. And really what happens is it's a threshold at which, beyond this point, dysfunction occurs. And the body is trying to maintain equilibrium. And if you hit beyond a certain point, equilibrium is unable to be sustained, which then leads to dysfunction. So if you told me, I want to take ashwagandha to improve my testosterone levels, but you're beyond your allostatic load, ashwagandha is not going to work. We need to reduce the allostatic load and reduce the burden on the body so that it can utilize the things that you put into it to improve its health. So, don't expect one therapy to have a profound impact. I think the most important thing is to make sure that you're hitting all aspects. You need to reduce environmental exposures. You need to have a healthy diet. You need to sleep well. You need to be supplemented properly. I mean, it's pretty obvious. Like, you give somebody selenium and zinc and their reverse T3 will go down. Well, does that mean that they're deficient in selenium and zinc? Probably, but there's also other aspects that are going on here that can have an impact on that. So I want to kind of bring it all together with that, is trying to understand it as the allostatic load, which then by addressing that will allow you to actually promote healing rather than just palliating or giving somebody a kind of overpowering the body.
Yeah, and that's such a great way to look at it. I talk about allostatic load quite a lot because for some reason I'm drawn to the bigger picture these days. So anything that is like a big perspective, I love.
Right.
And that idea that it's about reducing the strain on the body to it to do its innate healing and recovery. It's got the mechanisms required to repair and heal itself. So can we free up those resources to actually achieve that?
Right. Absolutely.
Perfect.
Right.
I think that's
great way to end.
Yeah, that's a strong conclusion. Brilliant. Well, thank you very much for your time, Ralph. I think this is going to be extremely well received, and hopefully we'll cross paths at a conference one day.
Oh, my pleasure. Really, please don't hesitate to reach out. And if your listeners want to reach out to me via social media, I'm happy to, be available to them. Although I'm not taking on patients. So
Okay.
with a grain of salt.
Perfect. Excellent. Well, thanks once again, and we'll speak soon.
My pleasure.